Good morning, good afternoon, good evening. You are welcome to these new aGvHD Junior Clubs. Today we have the pleasure to welcome Dr. Esra Gulderen, that is resident in internal medicine in Turkey, that is going to present us a very interesting case of acute myeloid leukemia that goes through allogeneic stem cell transplantation. And as the expert, we have the pleasure to welcome Dr. Dholaria, that is a transplant physician working in Vanderbilt University in Nashville, US. So please, Dr. Gulderen, you can share your screen and present us this very interesting case.
Thank you very much for having me here today. I will present the challenging journey of a young AML patient. Okay, here is the flow of my presentation. First, we will discuss diagnosis and management of AML, followed by the course of allogeneic hematopoietic cell transplantation. Finally, we will focus on transplant-related complications. In August 2021, a 22-year-old female patient presented to emergency room with persistent fever for last 4 days. Past medical history was unremarkable, and in physical examination revealed no findings except for pale appearance. Initial workup showed pancytopenia, complete metabolic panel, and coagulation parameters were in normal limits. In peripheral blood smear, we observed pancytopenia features together with 2% myeloblast showing high nuclear to cytoplasm ratio, immature chromatin patterns, and positivity for our rods. 58% myeloblast observed in bone marrow aspiration, which confirmed AML with maturation. Further confirmation made by flow cytometry, which was positive for CD13, CD33, CD117, and MPO. Molecular cytogenetic didn't show any translocation and normal female karyotype. According to ALN risk classification, our patient falls into intermediate risk category, and this classification guides us with more personalized therapy management. After confirmation of diagnosis, we promptly started hydration and supportive care. Patient underwent to 7+3 remission induction chemotherapy, which resulted in achievement of complete remission. We proceed with consolidation with high-dose cytarabine. Now, question is, should we move forward to transplant or not? Decision of transplantation based on risk-benefit ratio and according to non-relapse mortality and relapse risk. Here you see the patient, hematopoietic cell transplant recipient patient showed better overall survival when we compare with patient receiving chemotherapy after complete remission in intermediate risk group. Now we have AML in complete remission 1. Comorbidity index was 0. After completing all consultation, patient underwent to allogeneic hematopoietic cell transplantation from 10 out of 10 HLA matched sibling donor with busulfan cyclophosphamide conditioning regimen. GvHD prophylaxis was cyclosporin and methotrexate. Patient discharged from BMT unit without any severe complication and successful engraftment. During outpatient follow-ups, she developed abdominal cramps, nausea, and diarrhea. In differential diagnosis, we considered infectious pathologies and others, including drugs, conditioning regimens. After carefully evaluation, we considered grade 2 acute GI GvHD and started 2 mg/kg day methylprednisolone. Now, if we shortly review what is acute graft-versus-host disease, it's a common complication of allogeneic hematopoietic cell transplantation. It has an acute disease course and rapid onset. but there is no time limitation for initiation. In theory, graft cells recognize recipient host cells as foreign after activation of immunomilieu, and it is associated with high morbidity and mortality. Most affected organs are skin, GI tract, and liver, among other organs. It's important to differentiate from chronic GvHD. Sometimes it can occur as overlap syndrome. Risk factors are HLA disparity, stem cell source, conditioning regimen, and underlying disease. While prophylaxis is a key to prevent acute GvHD, in first-line therapy, we have steroids, but if treatment failure occurs to steroids, ruxolitinib exists in the second line, and in third line, there is no well-established algorithm, and many therapies are being well studied. Okay, now on day 61, diarrhea, severity of diarrhea increased and it needed hospitalization. In colonoscopic evaluation, spotted erythema, patchy aerasions, and scattered ulcerations in sigmoid colon demonstrated. CMV in tissue biopsy was negative. Mucosal destructions and crypt cell necrosis in histopathology confirmed acute GvHD diagnosis. We started ruxolitinib because it was now resistant to steroid therapy, and on day 72, worsening in echo performance score lead us to start extracorporeal photopheresis 3 times in a week. On day 79, paresis on upper extremities and sudden partial vision loss developed. Possible causes for these neurologic symptoms can be uremia, hepatic encephalopathy, drug-related infections, CNS relapse, stroke, acute intracranial hemorrhage, transplant-associated TMA or PRES. So what do we know now? There was no headache, motor functions was protected. We had grade 3 acute GvHD, no fever, no proof of infection, no antibiotics other than routine prophylaxis, no recently added drugs. Renal and liver functions were in normal limits, and MR showed left frontal and temporal subcortical hyperintense signals on T2 and FLAIR-weighted images, which was highly suspected for PRES. And what is PRES? Posterior reversible encephalopathy syndrome. Clinical signs are non-specific neurologic symptoms like seizures, headache, vision loss, paresis, and other clues can be radiologic signs and early course of allogeneic hematopoietic cell transplantation. It is an emergency situation, so we have to recognize early and treat immediately. It is typically reversible, but not always. Pathophysiology is unclear, and there are several well-established risk factors like hypertension and some immunomodulatory drugs, and we have to rule out other possible etiologies. So we removed cyclosporin from medications and controlled hypertension. So on day 83, anemia and thrombocytopenia requiring transfusion developed. Schistocyte in peripheral blood, increased LDH, creatinine levels demonstrated, and PUMS test and ADAM-TS test was negative. These findings was again very suspected for transplant-associated TMA. It is a rare but life-threatening complication of transplantation. Typical triad is microangiopathic hemolytic anemia, consumptive thrombocytopenia, and microvascular thrombosis. Altogether cause end organ damage, and it is related with unfavorable post-transplant outcomes, so we have to diagnose very early. There are several scoring systems to diagnose and make risk stratification for TMA, and for further evaluation, as I said before, it can cause some end organ damage. Like in our patient, kidney can be a target, and it can present with proteinuria, hypertension, acute or chronic kidney injury. In differential diagnosis, we should consider calcineurin inhibitors, steroids, nephrotoxic drugs, PK nephritis, and engraftment syndrome. In workup, we should consider urine analysis, urine culture, urine protein-creatinine ratio, and PCR for BK virus. While golden standard is biopsy for diagnosis of transplant-associated TMA, mostly we diagnose patients with clinical presentation and lab parameters. And other affected organs can be lung, GI tract, central nervous system, and patients can also be present with polycerositis. There are 4 main steps to diagnose and manage transplant-associated TMA. In first step, we have to screen our patients to prevent or diagnose very early with complete blood count, LDH, urine analysis, and regular blood pressure assessment. If there is any suspicion for TMA, then we should ask several questions if patient meet criteria. Either we should have tissue diagnosis with biopsy or 5 of these markers, including schistocytes, proteinuria, hypertension, thrombocytopenia, anemia, increased LDH level, or terminal complement activation. We can do some organ-specific workups as well, and we have to rule out several other possible etiologies like TTP, DIC, autoimmune hemolytic anemia, aGvHD, and infections. In third step, we should make a risk stratification and start very early supportive care, aggressive hypertension management, control of coexisting conditions like GvHD infections, and we should also consider stopping calcineurin inhibitors. And in the last step, we should, if patient has high risk TMA, we should consider plasma exchange and also consider complement blockage. So if we turn back to our case, now we have acute multidrug gastrointestinal system GvHD and PRES together. We added etanercept 25 milligram weekly to our treatment. Then transplant-associated TMA developed. We started therapeutic plasma exchange, but there was no response after a week. So we have high risk TMA now. We added eculizumab 300 milligram weekly to therapy, and cytopenia, need for transfusion, creatinine and diarrhea problems was solved. And we discharged our patient with ruxolitinib and MMF therapy. But what happened to PRES? 20 days later than initial symptoms, complete resolution in symptoms and MR findings all resolved. And in the 5th month, new onset of grade 2 diarrhea developed, and we added lithium and steroids again, but this problem solved in 1.5 months. Patient received eculizumab 9 weeks in total, ECP 6 months, and ruxolitinib 12 months in total. MMF was also tapered and discontinued later. So global access is okay because we were very lucky to have so many options to treat this complication here. And last words are, I would like to share some resources for trainees, including Chimera from EBMT training. And I also would like to thank my mentors and colleagues in Uludağ University, especially Dr. Bedrettin Orhan, for his invaluable contributions. Thank you.
So thank you very much, Dr. Gulderen, for this very clear presentation and this very interesting case. And we see that when we go through the journey of the transplant for the patients, it can be a very long journey with a lot of complications. So again, to all the attendees, do not hesitate to send your question in the chat. We have a first question for you, Esra, and after it will be for you, Dr. Dholaria. How often did you see this kind of complications, the PRES and the TMA? This is something frequent for you after transplant, or?
No, it is not so frequent, actually.
And for you in your centers, Dr. Dholaria?
Yeah, fortunately, we don't see these dreaded complications that often. I think we monitor the calcium inhibitor levels very closely, and I have felt that that's probably the best prevention strategy, which is keeping the tacrolimus and cyclosporin level within the narrow therapeutic window as much as possible, and preemptively manage the blood pressure. We also routinely monitor patients for proteinuria through the first 100 days and make adjustment in their medication. So we actually, interestingly, last week we had a case, and that patient started with an acute renal dysfunction because of unrelated problem and end up having supratherapeutic tacrolimus, and that led to triggering of the TMA in that patient.
Okay, so thank you, Dr. Dholaria. So yes, this is very interesting. In fact, the key issue when we manage this kind of patient, this is what we are supposed to do with the calcineurin inhibitors, because the first thing we want to do is to stop the calcineurin inhibitors, or sometimes try to decrease. But the thing is that it's the key into GvHD prophylaxis. So do you have any advice regarding what did you do when you have to stop the calcineurin inhibitors for the prophylaxis?
Yeah, we've been into this tricky situation in more than one time, unfortunately, and we have kind of made the decision whether to permanently discontinue calcineurin inhibitor based on case-by-case basis, really. So like you correctly alluded, first goal is to bring down the level of calcineurin inhibitor if we can. Again, these drugs are not easily dialysable, so but if the TMA continues to be a problem and we see the worsening organ dysfunction, then in those situations we have made a switch to the mTOR inhibitors such as sirolimus, which in few cases you can kind of help with the controlling this problem.
Yeah, this is the mTOR inhibitor that can be an alternative. I don't know you, Esra, if you have seen this kind of situation, because in this situation it was particular because patients already have graft-versus-host disease with ruxolitinib or other drugs. But have you seen some other patient when we have to stop the calcineurin inhibitors? And what did you use for the prophylaxis in this case?
For GvHD?
No, for the prophylaxis, because you have to stop the calcineurin inhibitors because of the TMA.
Mostly we shift to MMF.
Yeah, okay, you put MMF in this case. And and you don't see any higher rate of graft-versus-host disease in those patients?
No.
Okay, no, that's good, because this is always the difficulty for the management of those patients. I know some centers also use steroids, but in this case, it's not very effective for graft-versus-host disease prophylaxis, and we have a lot of infections, so it's not the best things to do, I think. And do you think, Esra, and then Dr. Dholaria, that ruxolitinib could be an option? We see at the last ASH meeting some nice data that suggests now that maybe ruxolitinib could go to the prophylaxis setting. Could you think it could be an alternative? Esra first.
I think, yeah, it could be. But we don't have so much experience with that, I think, so far.
Yeah, for full disclosure, I'm a PI on the aGvHD prophylaxis study at our center. So this was a phase 2 study where patients with AML MDS received ruxolitinib for primary prophylaxis for graft-versus-host disease for a year after engraftment. There was also a sister study done in a patients with primary or secondary myelofibrosis, where ruxolitinib was continued in a peri-engraftment period and subsequently post-transplant for GvHD prevention with the tacrolimus and methotrexate. And as Dr. Mallard mentioned, we found that, first of all, the intervention was safe. There was no negative impact on engraftment, because that was a main concern about introducing the ruxolitinib very early post-transplant, and it affects on the chimerisms, and we didn't see any signal like that. Second, we didn't see any significant increase in grade 3-4 infection complications. That was another concern. Although the doses of ruxolitinib was anywhere from 5 to 10 milligrams twice a day. But most important finding was that we didn't really see much grade 3-4 acute graft versus host disease compared to the historical standards. So currently, BMT-CTN is going to propose a trial, hopefully will open soon, which will randomize people to ruxolitinib-based prophylaxis versus post-transplant cyclophosphamide. So the next version of the PROGRESS trial hopefully will answer this question. I have personally never used ruxolitinib outside the trial for GvHD prophylaxis.
Yeah, no, same for us. So far, we don't use ruxolitinib in the prophylaxis setting. So, but this is very interesting, and we wait for this ongoing BMT-CTN clinical trial on the result, but it will be maybe in 2 years from now. It's now, if we go more in details into how we manage this TMA, I have one question from Dr. Madne that asks regarding the efficacy of plasma exchange in TMA in the presence of eculizumab. I don't know if you want to comment on that, Esra. Because what you do is you did first the plasma exchange and after the eculizumab, but it is feasible to use eculizumab on plasma exchange after?
No, because we have to do off-label application for eculizumab, and patients should be unresponsive to plasma exchange first, in our case.
And for you, Dr. Dholaria, that when you need to use this kind of drugs, you try directly the eculizumab, or you try also the plasma exchange first?
Yeah, I'm personally not aware of much of a prospective data on efficacy of plasma exchange in the drug-induced TMA or PRES situation. I would love to hear from your practice, of course, but at our center, we first do the supportive measures, such as adjusting the drug level, and we do a few sessions of dialysis. But beyond that, we start the complement inhibitors such as eculizumab, and we have seen some success in refractory cases. This is not an immune-mediated process in most situations, so I'm not sure the benefit of doing a plasma exchange. But what are your thoughts and your practice at your center, sir?
I agree with you. We start for the supportive measure. We stop the calcineurin inhibitors or decrease the level. We monitor the patients. Most of the time is managed in the intensive care units at this time with dialysis, and after we go with the eculizumab or equivalent drugs. And in fact, we don't use the plasma exchanges. But I understand that from your practice, it was mandatory to do it because you have this compassionate use access, and you have to say it doesn't work, even if you probably know that it will not work. So it was a process, I understand.
Because it should be a high risk situation.
Yeah. So you have to say, yes, it doesn't work, so we have to use eculizumab. We have a comment from Dr. Oran that say, thank you for this wonderful presentation, Esra. That is very good for the education. So, and yes, on that so that want to congratulate you on that. Say, yeah, that despite all this kind of stuff, people can relapse after, on that we have the complication about graft-versus-host disease. If we go back now a bit before regarding the graft-versus-host disease, because we have several questions regarding how we take care of graft-versus-host disease, and regarding the prophylaxis, there is one question. This is some people ask if we can use Ruxo as a primary prophylaxis of graft-versus-host disease. No, the answer is no. This is not approved from the FDA. So far, this is approved for the second line treatment of acute and chronic graft-versus-host disease. And for the prophylaxis, it is only discussed in the case-per-case basis. You can't give calcineurin inhibitors, you can give mTOR, and you really need to give something to your patient. So maybe you can use an off-label use of ruxolitinib, but it will be on very specific case. And we can't perform today any recommendation for the use of ruxolitinib in this setting, just to make things perfectly clear. For the management of the graft-versus-host disease, someone, Dr. Nayak, asked, do we need to repeat the colonoscopy in case there is a worsening of graft-versus-host disease? I don't know what is your practice, Esra?
I think we have biopsy and confirmation for acute graft-versus-host disease. I think we don't have to repeat it very frequently. But if you have other suspicions like TMA colitis, maybe it can be an option.
You have the same answer, Dr. Dholaria?
Absolutely. We actually don't do full colonoscopy. We only do sigmoidoscopy, and that's typically much safer for our acute aGvHD patient. But like you said, Esra, we do it at the time of diagnosis and then repeat it only if we are suspecting an alternate pathology. But really, in most situations, really don't have to repeat a scope because you just go by the stool volume and overall presentation of the patients. We do sometimes repeat a CT scan to understand the extent of the colitis and enteritis and kind of follow up, because it's an easy thing to do and non-invasive test. But we don't repeat the scope unless otherwise clinically needed.
Yeah, this is the same thing for us, only if we suspect CMV, adenovirus, and so on, and we want to be sure, and we repeat, but otherwise we never repeat only not the full colonoscopy, but just a rectoscopy. So just also we go back now to the first part of your presentation regarding the diagnosis and the management. So for these patients, so you decided to proceed to the transplant. So and you show the curve to say that in this kind of intermediate risk, this is what is associated with the best outcomes. And you go for these BUSI conditioning regimens, but this is also a very intensive conditioning regimens, and probably contribute to this severe graft-versus-host disease. Can you discuss the different kind of conditioning regimen that can be done in this setting?
Actually, I'm aware of lower conditioning consolidation, you mean, right? Consolidation regimens are better.
And for the conditioning regimen, because now you know that we have also some reduced toxicity conditioning regimen for Gulderen on high-dose busulfan, for example.
We had myeloablative conditioning, right? And it has higher risk for acute aGvHD, but on the other side, relapse risk is very high in these patients, more than 40%, I think, in intermediate risk group. And if you don't have MRD to follow up, and maybe to stay on the safe side, we can prefer myeloablative.
And for you, Dr. Dholaria, which conditioning regimen you will have done in these patients?
Yeah, so we have two preferred regimens when it comes to myeloablative. We use the fludarabine and high-dose busulfan as one of our preferred, and I think in United States that has become predominantly used chemotherapy-based myeloablative regimen for acute leukemia based on the CABMTR data. The BUSI has been used less and less often because of this higher toxicity with the double alkylator. And the outcomes are fairly comparable. We have seen that in our prospective trials. For our pediatric patients, they actually still prefer a TBI-based conditioning. So across the street at the Children's Hospital here, patients get TBI with cyclophosphamide or TBI with fludarabine as their preferred myeloablative conditioning. But they have the data to show that in pediatrics, it's safe and may lead to an improved outcome. But for adult, all acute leukemia get flu-bu.
Yeah, we will probably do the same. It will be myeloablative, but the fludarabine on the high dose, the 4-day of busulfan, because it allows us to have a high myeloablation to decrease the risk of relapse, but to reduce the toxicity compared to the BUSAI or to the SAI TBI. We just keep the TBI now, not for acute myeloid leukemia, but for acute lymphoblastic leukemia. That we know this is just in this setting, like in the children, that we can have a benefit to do the TBI. So I don't know, we don't have any more questions through the chat. I don't know, Dr. Dholaria, if you have some question to Esra or some additional comments or thought regarding this case.
Yeah, no, Esra, again, thank you so much for laying out this extremely complex situation, and I hope the patient is doing all right. Now, one question that came to my mind while I was going through your initial slide was the use of ATG, and I know Dr. Millard is a big fan of ATG at his center, so I would love to hear your thoughts, Esra, on does your center use anti-thymocyte globulin for acute GvHD prevention, and in what setting it use? And also, Dr. Millard, what are your thoughts on your center?
We don't use ATG frequently for prophylaxis, no.
No. So and for us, yes, you know, so we use ATG in Europe a lot. So we use now in the patient with the match-related or unrelated donors for this kind of patients. Now for mismatch-related donors on APLO, we use post-transplant cyclophosphamide. That is well established. And for APLO, of course, but for mismatch unrelated, we have really great result. And now when we have a 7 or out of 10 mismatch unrelated donors, we know with the PTCI we can have some good results. And if we don't have any other donors, we will go for these donors with the post-transplant cyclophosphamide. The question now is regarding the match-unrelated donors. Should we use ATG or post-transplant cyclophosphamide? We have some study that show that the results are comparable, but I think we need to go more in details regarding the kind of underlying disease we are treated, because it seems that, for example, for some disease, it may be more effective to have the post-transplant cyclophosphamide. So we really need this kind of study to have the definitive answers.
Yeah, we struggle after the PROGRESS 3 data came out, and I think even our groups, there was a lot of debate whether we should switch every unrelated donor to PTCI-based prophylaxis versus stick to our current standard, which is 4.5 milligrams per kilogram of ATG on day -3, 2, and -1. And we have not changed our practice, but just because our GvHD outcomes are fairly good, and we do worry about relapse risk with PTCI. Also, delayed engraftment you sometimes see when the cyclophosphamide is given on day 3 and 4, and the subsequent viral reactivations and hemorrhagic cystitis. So, but in the future, if the data stays true, and we may switch our practice, like many centers have already done.
So yeah, we still need to have some more data for us also before we change everything. So yeah, we are on the same line. So do you have any other comments? Or
one question I have is like, I know there is no standard of care treatment approved for a ruxolitinib refractory acute graft versus host disease. And what is your practice, Dr. Millard? In your practice, you have done a lot of work in gut microbiota, and you have done a lot of trials. But outside the trial, what is your preferred, like option 3, 4, 5, if somebody does not respond to steroid or ruxolitinib for acute GvHD?
oh yes, first line is steroid, second line is ruxolitinib, third line. So if there is a GI involvement, in fact, outside clinical trial in Europe, in France, we can have access to the FMT through a compassionate use program. So this is what we are currently using, including outside clinical trial, because we have access of this kind of drugs. And if we can't have access to that, before we are using methotrexate in this kind of patients with some good results. We try to avoid the use of ATG or anti-TNF-alpha, because we see a lot of infectious complications. And also we are using ECP. We are using ECP maybe sometimes earlier in the course, very quickly after we start ruxolitinib, in particular for patients with some skin involvement, because we have some kind of probably synergistic effect, and there is some few papers, one of them from Nicholas Kroger group that reported this. So it is also one of the alternatives. The last thing that can be discussed is that we have also the mesenchymal stem cells, but so far I don't have any experience with that.
Oh, thank you so much.
And for you, Esra, do you have some comments, some questions?
Thank you very much for this opportunity and discussion.
Thank you again. I don't have any additional comments at this point. Thank you for the invitation.
So thank you, both of you. It was very great Junior Club again. It was nice having both of you with a great case, some great discussion, some great question from the audience. So it will be available live in YouTube, and just keep posted from the next Junior Club that will take place next month. So thank you again. Have a nice day. Bye.
Bye-bye.
Thank you.